Hello, everyone. My name is Amanda Scott, and I am the Manager of Product and Membership Design at the National Quality Forum. Welcome to this latest program on how NQF members are responding to the challenges around COVID-19. We are glad you could join us, and we hope it will be informative. This program is made possible by you, the members of the National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances healthcare value, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our presenter today is no exception. As Chief Executive Officer, Abby Sears is responsible for the overall strategy and executive leadership at OCHIN. Abby has been with OCHIN since its inception and has helped grow the organization nationally, working to transform healthcare. By leveraging technology, data services, and the use of practice-based research, her work at OCHIN addresses differences in health that are systemic, avoidable, and unjust, to ensure all individuals have access to the best care. A prominent speaker and HIT advisor with over 20 years of healthcare expertise, she is a member of many regional and national boards, including an appointment to the ONC Health Information Technology Advisory Committee. Abby holds an MBA and MHA, both from the University of Minnesota. If we could advance the slides. Some quick logistics as we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to the information being shared today. We have muted all participants to ensure that unexpected noise does not interfere with the program. We will be taking questions through the Q&A box on your screen. Please use the chat feature if you are having any difficulties that can be addressed by our staff. At the end of the webinar, a brief survey will show on the screen that we ask you to complete before logging off. And with that, I would like to turn it over to our speaker, Abby Sears.
Thank you, Amanda. I appreciate that introduction very much, and I'm really excited to be on the webinar today and to talk a little bit about what we're learning related to COVID here at OCHIN. And give me 1 second to get the slides. All right, there we go. So for those of you that aren't as familiar with OCHIN, I'm going to do just a very quick brief overview. We have 3 divisions of our organization. We have a technology division where we do hosting of electronic health records. We've hosted Epic, NextGen, and eClinicalWorks. We've also installed Allscripts. We have a research division where we have our own investigators, and we partner with like 35 different organizations across the country, making our data available to other researchers so that the types of patient population that we work with predominantly has access to the same level of policy and analysis as anyone else in the country. And then we do a lot, we have some deep level technical assistance and support, especially around network engineering, practice facilitation. We have a deep bench of clinicians that are part of our organization as well. We have about 550 employees. We're located all across the country and growing every day. So this just shows a little bit of a graphical representation. There's really only 2 states we don't have contracts or provide services in across the country. We touch about 500 unique organizations. That is not physical locations, it's in the thousands for physical locations, and well over 20,000 providers. We're an avid innovator related to interoperability and movement of data. We try to make sure that we raise our hands, and we're some of the first people in the country to be part of moving data and testing data and being on the forefront of that. We were one of the first groups in the country that turned on the electronic case reporting on the national frameworks to make our data available to public health agencies nationally. Years ago in Southern California, we pushed data through the national frameworks during the fires that were happening down there so that they had access to our patients in case they needed it. So there are examples like that, hooking up electronically to Social Security Administration. We've had and been part of at least 170 peer-reviewed studies. And as you can kind of see, we really focus on the part of the delivery system that the vulnerable patients, a little bit more disenfranchised, uninsured, underinsured patient populations are predominantly seen. Over the next year, you're going to see us branch out, and we're going to be working with critical access hospitals and community hospitals as well. So we're going to have a full suite and touch the whole part of the delivery system. We have a huge longitudinal database of data. We have active claims data now and clinical data, so we've integrated both. We touch over 6 million unique patients that are active. That means they're actually being seen in the last 18 to 24 months, which is huge. If you look at our database, we have well over 30 million, many of which are not active and not actively being seen. It's a predominantly women and children, but not completely, and about 65% are at or below the federal poverty level. And for many of you that aren't familiar with what that is, because we normally wouldn't be, it's not something that we have to worry about. For a family of four, the federal poverty level changes every year, but it's roughly about $30,000. So put that into the context of, could you manage and could you raise a family off of $30,000 or less? And so 45% of the patients that are seen in our organizations that we work with they have significant financial hardship. It's also a very racially diverse population. I mean, as you can see here, 30% are served in a language other than English, which means interpreter services. A lot of the providers that are actually hired are bilingual or multilingual. And as you can see, a lot of the patient population is Medicaid, Medicare, and uninsured. And that's our mission. That's what we're all about, is really trying to drive for health equity around the whole country and trying to connect the fragments of the system that, using technology and data, that haven't always felt connected. Our patient population is very sick with multiple comorbidities. At least one of them have 65% or more chronic conditions. Another 50% have a secondary chronic condition. And of that secondary chronic condition, in the top 8 diagnoses, when you look at the data, are 3 significant mental health diagnoses. So they are chronically ill with a lot of mental health issues. And then I think if I can get to the next slide, yeah, they also are very, very vulnerable. We have one of the largest databases in the country of socially screened patients around social determinants of health. We have well over 500,000 unique screens on unique patients, which isn't nearly enough, frankly, but it's still more than the majority of the organizations in the country. And what we can tell you is the social deprivation of our patients is huge. They have some of the highest levels of poverty. I kind of explained that. They have some of the highest levels of unemployment. They don't have transportation. They have challenges with, like I was saying, mental health issues. So again, very vulnerable patient population, difficult to be seen and to stay on regimens when they get treatment plans. And sometimes in very remote areas as well. I kind of talked about this for a minute, which is the social determinants of health factors. And as you can see here, I was speaking to the amount of data we have and the types of data we have: homelessness, hunger, education, transportation, utilities. What we're doing now with this data is really bridging between our sector of the delivery system and more of the mental health and predominantly social services part of the system. We have 2 active large projects going on connecting social service resource locators, which again, that's a lot of IT speak, but what we're really doing there is connecting interoperability programs that are connecting the social service entities and trying to make the referral process more seamless for our patients to be able to move back and forth from all the different parts of the services that they receive help from. And we're learning some really interesting things. We're learning that there's not a lot of standards. There's not a lot of definitions around what good quality care looks like. We're learning that the social service and the public health parts of the delivery system are grossly underfunded. And you have to be operable to be interoperable, which means that you have to be on an electronic system. Many of the social service agencies that we refer patients to are still using pen and paper. So how do you possibly move data back and forth and make a more seamless experience and create more likelihood for our patients to get the support that they need and the help that they're asking for? There's a challenge with the providers on our side of the delivery system related to bandwidth, related to knowing what to do with the patients when they see, like, how connected can we get them to other agencies, and is it their job to do that? Whose job is it to do that? But everyone wants to help. So we're really looking at ways that we can do that. We have a lot of research projects. In fact, almost all of our research projects that we work on now at OCHIN have some element of social determinants of health, even if we're doing clinical trials or comparative effectiveness research. We're really looking at all of the different social elements related to the patient and what's working or not working related to treatment or outcomes specifically, and our metrics related to outcomes, and why is our diabetic population struggling, and can they adhere to the protocols, and what modalities are most likely to create adherence to the treatment plans. Switching now just for a minute about when COVID hit, you now have a little bit of a picture about what it looks like at OCHIN and the types of organizations and the types of patients that we're connected to. And then COVID hit, and what happened at OCHIN and our members when that happened. And we are very, very proud of the fact that within 1 to 3 weeks, 60 to 80% of our members were doing virtual care. And I can actually say 60% of our organizations had transitioned to virtual care within a week. And that's huge for this part of the delivery system. Imagine what they had to go through to actually have that happen. And so we're really, really proud of that. We do a lot, and have been working a lot on the telehealth legislation related to parity. Our organizations work on a very, very small margin. There's almost no margin. So when you get paid a little bit less for telehealth, it incentivizes the face-to-face visits. But what we're truly seeing, and what we've seen during the pandemic, is that it's really breaking down. In some ways, it's aggravating some of the equity issues, and in some ways, it's really breaking down the equity issues. And where it's breaking it down is that our adherence and compliance to scheduled visits is up significantly than what it was prior with the telehealth visits. I think that the transportation issues, I think the challenges of the chaotic life from time to time that they have, makes it easier for them to have and maintain their visits telephonically or through telehealth and video. What it also is doing, though, is actually weaving a story about how challenging technology and how much farther we need to go from a technology standpoint and a delivery system standpoint related to cultural competence. We have heard of examples where we're trying to embed interpreters onto the system or onto the video visits with our members. We've heard examples where they have pay by the minute phones, and they're not comfortable using those for video visits because they cherish those minutes and they need them for other reasons. So how do we make sure that our patient population has the same access? So in some ways, some parts of the delivery system have more challenges, and in other ways, it's really leveled the playing field and gotten more access. So that's been really exciting to see, and our membership really does not want to go backwards. The providers like it, the members like it, the health centers like it, the public health likes it. We've also done some really great things related to mobile apps, where we've worked in specifically the state of Washington, where we've gotten some really sophisticated apps delivered, connecting our database and the entire Epic database across the country, in building screening tools that has really much more facile registration capabilities, so that we can reduce the duplications and the patient duplication issues, and make sure that we're connecting labs results and making sure that those lab results are being matched and the results are being made available, both at the point of screening, but also available to the patients and also available to the public health departments across the state of Washington. So we're really proud of the work we've done there. We were called in by the state of Washington, called in by Epic themselves, and asked to participate, and we cherish every part of that, because it's exactly why we are who we are, and we're excited about what we're learning related to that. We're also excited to make those learnings and create the opportunity for those applications to be available to the entire membership, and that has also happened. So what we've been able to learn and innovate around for the whole state of Washington, we've been able to make that available in other communities all across the country. And we've also been awarded $2 million from the FCC related to deployment or getting more devices out into the hands of our members. And we've always been on the grant side, meaning we ask for grants to do the work we do. And this is the first time we've ever been able to create a grant process. We had $2 million to distribute across our membership. And we built a granting process within 3 weeks. And the beginning of next week, we will be awarding packages of physician in a box, diabetes in a box, hypertension in a box, and then a la carte requests for home monitoring devices. So we're excited about that as well. And we did all of that within, I think we're right at around 55 days. So we're pretty proud of the work we've done there, and getting a lot more tools into the hands of our members as well. So talking a little bit more about the momentum, what we've created related to virtual care, as I kind of said, 1 to 60 within, it was actually I think it was about 7 to 10 days, and then getting up to about 80 within about 30 days. Some of that was telephonic, but we're still really excited about, we got back to about 90% of the visits within, I think, about 60 days. And you can kind of see here, we're back up hovering around 95%. We're hovering around 35 to 40% for virtual visits in general, including video and telephonic. And we're really excited about what we're seeing with that as well. And I think we have some graphs to show you here as well. So this shows you this really lays it out. I think this is a nice visual of how, we did take a hit in access in the first, right around the middle of March, right when it hit everybody. But you can see how quickly we geared up across the whole membership. And that's a lot of visits, a lot of providers. That's a big hike. And you can see where we're kind of hovering now. And we really are staying pretty consistent. Video visits still continue to be something we're really pushing for at OCHIN, but the members are struggling with it a little bit more, because the patient population, it's not easy for them to adapt to Zoom or Skype or some of the other tools because of the access to cell phones, and also the really significant issues that we're seeing in rural areas related to broadband. And I know you're hearing a lot of stories about that. but we're really experiencing that. So at least we know we have access, and at least we know we're maintaining our connections to this patient population, because it's important for us to be doing that and staying on top of keeping them on their treatment regimens and keeping them out of the emergency room. Next slide. So we also have one of the specific areas that has been the most successful transitioning to telehealth, which we've been really fascinated to see, is the behavioral health area. You can see they're roughly about 50% face-to-face versus 50% telehealth. And you know that we sense that actually might stay. It really lends itself well. It's creating a ton more access, especially for a lot of our people that are in substance abuse treatment. And it's really bridging the gap, especially in those rural areas where they don't have the same access to care, and where we're able to keep them in treatment and keep them seeing their behavioral health specialists and keep things moving in the right direction for those patients. Next slide. So one of the things, though, that we're really seeing, and is a consequence of this rapid deployment, and we're really seeing a lot of equity issues related to patient mismatching. We have seen in our patient population, our Latinx or Latino patients are about, I want to say, roughly 2.8% more likely to be tested positive for COVID. Our African American or Black population is about 1.6 ish percent times higher to be testing positive for COVID. So not only is our patient population testing positive more, but we also have a significantly higher rate of patient duplicates or patient mismatching when we do our interoperability on a national scale. So if you take the electronic case reporting or the movement of data to the public health agencies, what we're really seeing is that our Hispanic population is 21% of our population, but they're 35% of our duplicates. Our African Americans are 13.6% of our patients, but 22% of our duplicates. So we are getting hit, one, with a higher population of testing positive, and we're getting hit with a higher level of mismatches, which is going to be a significant problem in two areas coming forward. In the contact tracing area, it's a serious challenge, because if our patients are more likely to be COVID and our patient population's data is less likely to move because of mismatches in data or erroring out because there's a possible discrepancy in matching algorithms, then that data is not getting to the right place to make sure that as a country, we're able to track who has been tested positive and who has been in contact with them. And there are all kinds of other issues with contact tracing as we're trying to get better and better at doing this in our country. But this is a significant one that I think we tell a very interesting story about, and I think it's something we really need to think about as a country around the systemic issues in our infrastructure, around the challenges because we don't have a unique identifier. And I know there's a lot of concern about having a unique identifier, but we've got to find some way, if that's not the right way, to be able to handle the levels of mismatch. So let's talk about that related to metrics and measurement for a minute. If you have that level of mismatch and data that's not moving or available, or parts of data files, or you're looking at reports or aggregate reports on metric outcomes, those patients that are mismatched are not part of that calculation. So we are underrepresenting the significant amount of issues related to certain populations because of the patient duplication issues. So I think that not only is there a problem from a COVID and a pandemic standpoint, but even if we weren't in a pandemic, we're having issues because that data is not moving to the hospitals where they might need it for treatment purposes that are more acute. It's not necessarily being calculated into our understanding of some of these aggregate reports related to metrics outcomes reporting. So all of those are things we need to be thinking about, especially at the NQF, around what does it mean to have high quality care, and how are we handling the systemic issues related to some of the equity issues that we're seeing in our delivery system. Here's another fascinating one. Our pediatric patients, and we cannot, so we're doing a lot of research and putting in a lot of research proposals in a lot of these areas. One we just cannot really grasp is that our pediatric patients are mismatching at a higher rate. Now, why would that be? And what we need to keep doing is uncovering and seeing, again, do we have a higher number of, Black, Indigenous people, people of color. There's got to be something that's going on with that. But again, it's a problem if we're thinking about vaccines and we're thinking about our immunization registries. If just at OCHIN, who is pretty sophisticated, we have a sophisticated organization, and we do a lot of technical assistance and support with all of our membership, and we're still getting 35% duplicates on our children. That's a problem. It also signifies the significant amount of implications that we have to be thinking about and kind of contemplating related to when the vaccines come out, just for this pandemic, but also for childhood immunizations and the registries. Next slide. So I want to talk for a minute. I kind of touched on this, but we've got patient safety issues. We have patient safety issues, not just with the patient that wasn't matched, but with the patient. We have patients, if we have a duplicate, a potential patient duplicate, and we have two patients that look like they're the same person, and we have an abnormal test result come back from a lab, not only are we impacting the patient that has the abnormal lab, how do you know which one it is? So it's twofold, it's compounded. And that becomes a significant patient safety issue. And as I've kind of talked about, it's for the person that looks like it is a match, and it's for the person that originally is the originator of the test results. So think that through related to vaccines and other things. It's not just that individual patient, it's the combination of both patients that are tied to that. How do we know that we're getting the right results? How do we know that the right information is available for clinicians and providers? And these are the types of things that make providers crazy. Makes them uncomfortable, makes them not trust the systems, it makes them not trust their data, it makes them not trust the reports. These are the types of underlying issues that we've got to find solutions for. It also has a significant disproportional impact on our patient population, which I've actually talked about a number of times, but the liability and cost implications to this for this country, I would love to actually have an analysis done related to what we are wasting in money related to what I'm talking about. And if that was redeployed into care, it's not about what we're doing for patients, it's about where we're wasting money in our system. And we've got to focus on that. Next slide. So I want to touch and move to the challenges that we're seeing that are being exacerbated because of COVID. And I think everyone's having challenges with referrals and access to specialty care during COVID. But if on a normal day and we're not in a pandemic, you were having this level of challenge getting to specialists, and then you add in COVID, and then we wonder why our patients are presenting in the emergency room. There's not a big leap to understand why our system is costing us more money than it should. Our rates of referral are 32% less for an uninsured patient in our population. And this is data we've gone back on multiple years on. The top 10 reasons for referral are dermatology, endocrinology, behavioral health, kind of what you would expect. Our time to appointment is 50 days. What's important about this is the longer the delay is for the appointment, the more likely there's not compliance with keeping the appointment, which is going to aggravate the specialist wanting to actually see this patient population. But if it's going to take you 50 days, our patient population has probably, we cannot confirm this, and we actually are now starting to sift through claims data. Are they actually showing up in the emergency room then because they couldn't get into a specialist? And if you didn't have a cancellation and they're holding that appointment, it's making the specialist more likely to not want to see our patient population. So you can kind of see the unintended consequences of some of these access issues. About 75% of our referrals going outward, and they're about 60% of them are have a significant wait time. So I think it's about 25%. Let me see if I can catch my notes here for a minute. And with an average of 60% longer wait time. That's exactly it. So again, I think you can see that we have a significant referral and access to specialty care issue. When we see our own patients in our own system, which is 25% of the time, on average, we're seeing them within, I think, about 2 to 3 weeks. So it makes us want to have specialists in our own system that are only available to our patient population because we need to get them that access. And I don't think that's the answer to this. We've got to find another way to answer this question and create more incentives and more availability for us to actually make sure that our patient population through e-consults, and I like to call it phone a friend, which is the e-consult process, the ECHO programs around the country, and really televideos, telemedicine videos, so that we can create more access for this patient population. Next slide. We just finished a publication that was just released in the Journal of American in the AMA that really speaks to some of what I've been talking about in this presentation all along. Despite the limited test availability, our CHCs are reporting thousands of COVID tests with 28% positivity, underscoring the important role that this part of the delivery system is playing for everyone's public health. I've often talked about on a national forum that we've underfunded public health so drastically as a country that a lot of that is falling to the community health centers, the FQHCs in this country, and this only goes to underscore that more and more. And that's not the answer, but it is a part of what's happening. Also, from March to May, our rates to our face-to-face visits have significantly gone down, and they've all declined for, you know, our more traditional chronic care. And what we're really worried about is there's going to be more of a pent-up demand for that care. And we're really watching the visits to kind of see what's going to happen next related to that. Next slide. So I want to kind of begin the process of concluding today and really talk about what we've learned and what we think will help. We really got to continue with the innovation. We've got to continue to optimize the delivery models and make sure we're supporting the workforce, make sure that we're finding ways to get more workforce into this part of the system, but also helping them use this technology and be more comfortable using the telemedicine approaches. We need more APM, advanced payment models, or value-based pay contracts in the country where we're incentivized to use the less expensive approaches for telehealth, telemedicine, e-consult. Right now, if you're going to pay, I'm just making up a number, $50 a visit for telehealth, and you're going to pay $100 for a face-to-face, no one is going to be able to stop the movement of going back to face-to-face, and it's not necessarily the best approach long-term for our patient population across the board, whether they're commercially covered or not. We need to sustain the digital transformation. We've got to incentivize more innovation, and we've got to care about more of the vulnerable patients populations, the 30% that English isn't a second language. We've got to care more about it being more culturally competent. We have a huge Asian population in this country, and I know there are significant issues from a technology standpoint. For those of you that ever listened to Radiolab, I listened to one recently that was amazing about, you know, how they're trying to translate the Chinese characters into something that can be used on a laptop, so that we actually can build the technology to be able to provide the more appropriate care in a timely way to this patient population. Next slide. And again, you know, this pandemic, there's a silver lining in all challenges in the world, and the real silver lining is we've seen what's possible related to disrupting the way that we provide care and closing the gaps related to using technology. But what we really need to start asking ourselves as we go forward, what's the best way? How should we be paying for healthcare? And what's really how do we really measure success for socially and medically complex patients? Is success a metric around diabetes, or success a metric in keeping somebody employed and holding down a job and keeping them out of the emergency room? So how does the NQF, how do all of the people that participate in the National Quality Foundation and Forum, and how do we really think about this patient population in a completely different way, and what it means to measure success? And how do we incentivize the use of technology for doing that? Do we have enough metrics that articulate the quality of care related to technology? And then how do we reinforce what we've learned in this pandemic? And how do we make sure that we don't have a have and a have not in the system related to broadband and fiber access and public health infrastructure that we've not set as a priority for a long time? So those are the things I really think we need to be thinking about. And I think that this pandemic has given us a lot of lessons. I've talked about some of them today. Others have really great learnings as well. And how do we collect those? How do we set an agenda that will help answer some of these questions and put us on a pathway so that when this happens again, hoping it doesn't, but if it does, how do we make sure we're more ready and the entire parts of the system are connected more? And that's all I had for you today. And thank you for the opportunity to talk about what we've learned.
Thank you so much, Abby. You presented some very useful information and given us a lot to think about. We do have some questions from the chat, and if anyone else has questions, please enter them into the Q&A box, or we will also unmute your line so that you can ask them directly. But from the question and answer box, has anyone had multiple provider visits with patients via telehealth, like an interdisciplinary consult? Just thinking about collaboration between providers for those complex folks.
Yeah, they have, especially using telehealth and connecting with the e-consult and or with the telehealth visits. Not as much as what we'd like to see, and that's really where we want to go even more, but especially in communities where the relationships are really close. This is kind of the irony of the situation related to connectivity in rural areas. Sometimes those relationships are the best relationships, and they have some really strong community partnerships, but they might not have the broadband and tech and connectivity capabilities to do some of this. But that's where we've seen the majority of it. I will say in the urban areas, it's a little bit less, it's a little bit more fragmented, and it's a little bit less of a community approach. That's not always the case, so I'm generalizing, so please take that in context.
Okay. Do we have any other questions from our participants? Again, your lines are unmuted. Please mute them after you've asked your question or use the Q&A box. So we have one more. Did you have any challenges with clinical and non-clinical staff accepting telehealth?
No. What was one of the most shocking things was the lack of issues. I think one of the biggest challenges I heard around the membership was actually not the use of telehealth and not the adoption of telehealth, but that our organizations had never even considered or the thoughts of working virtually from their homes. So they were scrambling to get providers, clinicians connected to their home in a safe and secure way. And once that happened, that's how the adoption rates went up. So they didn't have a problem seeing their patients that way. But what they did have a challenge with was they were not set up for working from home like a technology. I mean, we we decided on a Thursday that we were going 100% remote, and on a Monday we were 100% remote, and we haven't come back. And we actually are not ever going back. We're selling our building. That's much different than what they have to contend with, and they were just simply not ready for that.
Okay, and then a follow-up to that question. I just want to make sure I get this. Sorry, I lost the question for a second. Did patients have concerns with telehealth? And if so, what did you do?
I don't know that the patients had concerns with telehealth, like from a privacy or anything like that. They have challenges getting connected. They don't have what they need to get connected, and if they do, they need a lot more support to get connected. I don't know how many of you have had a telehealth visit during COVID, but I had one, and it was really interesting. I had the MA, I think it was the MA, called me. You know, I got on there 15 minutes before my visit, and she made sure everything was working. Well, it took our members a while to get those workflows down. So what they did originally was they went straight to telephone. They just went straight to telephone, and then they did drive-by in their parking lots. Where they hooked up broadband. And they did some very interesting stories like that. But then eventually they got to where their providers were working from home and they were connected and their patients were more prepared. But again, like I kind of talked about, we have some challenges in the delivery system related to broadband access. So they have to be on the telephone. And having devices that you can really do video on. And eventually you're gonna have to do video or see them in person because you can't just keep doing telephone.
Okay, we have one more question. Do you see the COVID-19 pandemic breaking through any of the barriers to greater interoperability? Is there a breakthrough that COVID-19 is forcing to happen?
I think that electronic case reporting is a good example. I just saw a presentation yesterday on the ONC committee where there are now 4,800 organizations are moving data on the national framework for electronic case reporting. That's huge. And that happened in, I don't know, 30, 60 days. So I would say that that is a really good example of what can happen when we put our minds to it. That's not without some challenges, and we have some electronic health records companies, I don't know who they are, and I almost didn't even want to know when they said this, that are simply saying, we don't plan to do it. I can't grasp why they would not hook up and make sure that the clinical data is moving. That's mind-boggling. But the majority of the organizations or the vendors are doing it. And you know, 4,800 organizations, that's not a small amount of organizations. So that's a huge lift. That's really big and really important. So I think that's great. You know, one thing I didn't put in here that I would love to touch on for a second, Amanda, that I think people might be interested in is we measure our provider burnout. And we've been doing a lot of work around how do we make sure we're taking good care of our clinicians? And how do we be good stewards of the technology as well? And we've noticed in the last couple of months of survey data that our burnout has increased by about 10%. It was running 24, 25 up to 34, 35. Directionally, that's about what we're seeing in the numbers. And, you know, we've been having some conversations about why is that? Is it because we're all burned out? And I think there's a certain element of that. It doesn't matter who you are, you're tired of COVID and you're tired of the pandemic, and we'd all like to move on with our lives. Or is it because there's actually more compliance to the scheduled appointments? And so where our providers might have maybe had a no-show rate of 15 to 20%, and maybe they were overbooking, but maybe not completely overbooking. And they might have had some downtime. So do our providers have Zoom fatigue and telephone fatigue? And are they actually seeing more patients? And is that why we're up to 95%? And so there's some really interesting questions we're starting to ask of that data, and also about the burnout, because we're really worried about the clinicians out in the field. As I know that everyone on this webinar is, you know, they're doing the work of heroes, and I can't underscore that enough. And so it's really important to us that we're understanding what will help them, and that we're moving out any constraints or barriers to make their lives as easy as we can from where we sit.
That's an excellent point. Thank you for bringing it up. So we have time for one more question. If anyone has one more question, this will be our last call for those. Okay, so as we get ready to close, Abby, thank you once again for making the time to share with us your experiences in dealing with COVID and presenting us with data and information that we could use. I would also like to thank all of you, our participants, for joining us today. We hope the information that was shared today will be informative as you face these challenges in your organizations. We know that many of you are on the front lines of the response, and we are grateful for your leadership and action. Again, as the webinar closes, you will see a survey in your browser. We do ask that you take a moment just to complete those quick questions. And we encourage everyone to tap into our amazing community of healthcare quality leaders as we navigate these challenges together. We have an active conversation underway on our member online portal, which is Member Connect, and a recording of this program will be posted there shortly. This concludes our program for today. On behalf of everyone at NQF, we wish you continued good health. Thank you so much.